So I forgot to start recording, so I began recording now, and I will share the document, which is the PowerPoint slides. All right, so good morning, everyone. So today we are going to continue the content on the musculoskeletal system and the conditions that pertains to the orthopedic conditions, especially the total hip and total knee replacement and the fractures and all the management that are associated with the fractures, different type of fractures. But we will focus on the hip fractures. So last time we covered the osteoarthritis and rheumatoid arthritis. Okay, so we covered the content up to this slide, right? So we said that the surgical interventions to treat the osteoarthritis goes into, or we'll begin with the, depends on the scenario, or depends on the, on the patient's condition and the stage of the disease itself. Then the intervention will be determined. So like the osteotomy, we have another surgical procedure called arthrodesis, and then the most common one, which is the total hip or total knee replacement. So here we'll start with a total hip and then total knee replacement. Replacement, or we can also say arthroplasty or replacement. The osteotomy, that's in the, can be used in the early stages of the hip osteoarthritis. So when the joint is congruency still exists and the motion is relatively normal, that osteotomy, which means that they cut across the bone with like a resection of the bone fragment, and that can be done to correct deformity. Sometimes babies are born with sometimes anomalies and deformities, and this osteotomy can be done for that. Or if there is stress in the joint due to the osteoarthritis, that's all can be, we can do osteotomy. The partial weight bearing. So this is one of the strategies, one of the modalities or things that we will learn in the orthopedic, which is weight bearing in the joint. How much we we can put weight on the joint, which means stress on the joint. Can we put full weight or partial weight or no weight bearing? So the partial weight bearing is required for at least 3 months after this type of surgery to allow for the healing of the osteotomy site. Osteotomy is more frequent and or more frequently performed on clients or patients in their 40s. With a full expectation that the total joint replacement will be needed in the next 10 to 20 years. The arthrodesis, which is called also, you can call it a joint fusion procedure. The initial fixation may be provided with either pins or plates or braces or even cast. And it's indicated for the joint damage or instability of the joint that's cannot be repaired. So we can say that the hip arthrodesis remains the operation of choice for the active client less than 55 years of age with advanced unilateral osteoarthritis. So if the patient has a one side, let's say hip or knee osteoarthritis, unilateral, and a patient who's active patient less than 55 years old, that would be one of the one of the modalities to be suggested or recommended. Or patient with what is called post-traumatic arthritis, who had developed arthritis post-trauma, or patient who had developed the osteoarthritis due to what is called septic arthritis, which is arthritis due to the infection to the joint. The hip fusion, because in hip fusion, they will cut a piece of the bone, then that will result, which is the edges of the bone, because they will create like fracture and then the healing process will take place. So the hip fusion can result in a shortening of the affected extremity, about 1 or 1.5 inches shortening. So
which one is that for?
I'm sorry?
Which one is the shortening?
That's for the fusion, because when they do this arthrodesis, it is a hip fusion. So that will result in a shortening of the affected extremity, the one that they undergo the surgery on. So the client needs a shoe lift post-op. That's to maintain, so they can have a normal gait. And they may experience also low back pain due to that limping or that shortening of the affected extremity. That's why it's important that they should have that shoe lift always weird or on, so that would prevent the low back pain post-op. The most common procedure to treat and the optimal and the ultimate, modality to treat the osteoarthritis, especially with the severe cases or advanced scenarios, is to replace the joint, which is called arthroplasty or replacement of the joint. Now, we said that the most common joints that are replaced would be the knee and the hip. So we'll start with the hip, and then the knee replacement will be pretty much the same, except for one simple or one single, difference, which is the addition of, in some orthopedics, orthopedic surgeons will add what is called a CPM machine. It's not necessarily that has to be used post-op for all knees knee replacement surgeries, but some, for most, or some orthopedic surgeons, they do recommend the CPM machine, and we'll talk about the CPM. So that's the one of the very few differences between the knee and the hip replacement. So we'll focus most of the discussion on the hip replacement.
I'm sorry, Dr. Mickey, you said that the CPM machine is used for the hip?
For the knee.
For the knee, okay.
Yeah. So goals of joint replacement: alleviate pain, obviously, and then to restore joint motion, improve functional status, improve quality of life. And the indications for the joint replacement in general is the advanced osteoarthritis or rheumatoid arthritis. because both conditions, they can cause cartilage destruction and damage. Or babies are born with congenital anomalies, trauma, osteonecrosis or avascular necrosis, which usually develops status post the failure of previous fixations. So if they do have, previous fixations were performed, and the failure of these fixations then will result in something called osteonecrosis or avascular necrosis. Avascular means the necrosis have resulted or yielded because of the decreased perfusion to the fractured area, which is here, it's the joint replaced in this case. So when this total joint replacement cannot be or is contraindicated. It's not recommended. Well, inability to cooperate with immediate post-op requirement, because post-op requirement requires specific patient teaching and specific, things that should be prevented or avoided, or things that have to be maintained. So it needs a lot of education and a lot of commitment to the post-op period from the patient side. So and especially when there is a long-term joint rehabilitation. So if the patient is unable to commit to these post-op requirements, it's contraindicated for that patient to have this surgery. If the patient have an active infection, active osteoporosis, or arterial impairment, because that could result in the avascular necrosis, or uncontrolled diabetes or hypertension. In addition to that, or like any other surgery, the patient should be cleared medically by the PCP. Primary health care provider should, or the medical doctor is supposed to, or nurse practitioner supposed to clear the patient medically for the surgery. So in the client's general health must allow tolerance for the anesthesia, for expected blood loss, and for surgical stress. So patients with heart, lung, liver, metabolic disorders, all of these should be stabilized before surgery. Or if there is any disease affecting these organs, supposed to be stabilized before surgery. So the total hip replacement can be either a first, like primary surgery to replace the joint, or to revise, revision. And the criteria is, for the total hip replacement, when it's refractory to pain management and a failure of the conservative treatment, that is a criteria for the total hip replacement. When the hip or the osteoarthritis and associated manifestations will compromise the patient's ability to function and do the ADLs, that's another indication or criteria for the replacement. And criteria includes that the patient is able to commit and able to participate in the post-op PT therapy and rehabilitation program. And the criteria is when the patient experiences that pain due to the osteoarthritis or arthritis, that pain will interrupt patient's sleep, or if the pain limits the patient's ADLs. So pre-op care, I'm going to just to highlight the most important. There are some, like routine stuff and steps and things that can be done for any other surgery. But let me just highlight the things that are, pertain to this specific surgery. The first one is that because if we are going to use the general anesthesia, we, recommend that patient will have a cervical or cervical spine X-ray to rule out rheumatoid arthritis. Because if the patient has a severe rheumatoid arthritis, that is one of the indications not to use the general anesthesia, because general anesthesia means that you have to intubate the patient, and patient will be under the general anesthesia like clothane or nitrous oxide. So the X-ray is to rule out rheumatoid arthritis. If their GA or general anesthesia will be used, otherwise they'll use spinal, epidural, and other types of anesthesia. The second most important thing before or step before the surgery is to make sure the patient had performed or done any dental procedures prior to the surgery, should be done prior to the surgery. Because the dental infection, any dental infection after surgery, the bacteria could migrate to the surgical area and kind of ruin the whole thing, damage the whole, procedure, and result in something called prosthesis failure. So prosthesis, which is the new joint that has been replaced or implanted, now that becoming, the area is infected, and then that would result in a prosthesis failure. So the dental procedure should be done prior to surgery. Anticoagulant should be held before surgery. And this is one of the areas in which some practitioners will, sometimes it's been overlooked. And they forget to hold the anticoagulant, and they'll until the patient is in the OR, on the table in the OR room, and the operating room, and they will find out that patient is still had received the aspirin or Plavix or Lovenox or heparin prior to the surgery or that morning. So then they have to cancel the surgery and reschedule the surgery date. So the anticoagulant medication should be withheld at least 3 days, if not 7 days, pre-op. These are some of the prostheses that will be implanted. Because this is a total hip, then we have to use something called osteomore. This is called osteomore prostheses, because the osteomore prosthesis can be used also just this prosthesis without the acetabulum piece. Like in this scenario, or the next one, which is this one, without, because this is not the total hip. The total hip is this one, because you change the head of the femur, the neck of the femur, and then part of this will go into the shaft of the femur, and then this is where you create a new acetabulum cap for the head, and that will be implanted into the acetabulum. Create with the osteotome a place in the acetabulum, nicely sitting. This one will be nicely sitting in the acetabulum, and then we can either fix it with screws or with cement. So there are two different ways: cemented or non-cemented method. But this one is called osteomore. This one is called osteomore prosthesis. And the fracture of the femur it depends on the level of the fracture. Let's leave it here. The level of the fractures. Some fractures like this one is the subcapital. This is because this is the lesser trochanter, greater trochanter. So this is the subtrochanteric fracture. So this is below this the trochanters, the lesser and the greater one. Subtrochanteric. That's capital. So that's transverse fracture. The intratrochanteric. This is right into the trochanter, intratrochanteric, right between the greater and the lesser trochanter. So there are different lines, levels of the fracture. That's the subtrochanteric or above the trochanter or intratrochanteric. So there are different different levels of the fracture, which guides the orthopedic surgeon to decide what type of the modality to use, total hip, or to use the pins and plate, or so all of these surgeries is called ORIF, open reduction internal fixation. All of these modalities is called the open reduction internal fixation because it's the invasive procedure. So it's open reduction. They have to open, to get through the skin and the fascia and the muscles to get into the bones and fix the fracture. So this is a total hip replacement. So they have to change all the three components, which is the head, the neck, and then the part of the femur will be also removed. So they will implant most of the osteomore into the shaft of the femur, and then the head will go into the new acetabulum. So post-op care, the most important nursing care after the total hip replacement is to prevent dislocation. Prevention of dislocation requires that the patient, first of all, we have to maintain the abduction, both legs to be away from each other. So to maintain the abductor pillow, you can use abductor wedge pillow or any type of physical separator, or something to put it in between patient's legs. But if you have that abduction pillow or the wedge, a pillow, that would be great because that will maintain the abduction of the lower extremities. So we have to avoid the adduction, which is the legs to come in like close to each other. That should be avoided. It's what we have to also encourage the patients not to assume any positions that will result in a 90-degree flexion of the hip, like this. So as we take a look at A, B, and C positioning, which one reflects the hip joint to have a degree more than 90, like more than 90?
Is it C?
C, because the angle, it's actually goes like the patient seating, which is patient the head of femur with the back. So bending the back, so when the patient bends forward, when they bend forward, then that is going to increase the the angle to be more than 90. So it's the angle between the patient's back and the posterior aspect of the head of the femur. So this position is okay because patient is going to support first of all, is not assuming any position more than 90 degrees flexion of the hip. So it's 90 degrees about. This one is less than 90, which was from, this is the angle right here. This is less than 90. This one is more than 90. So C, it's not recommended. Any position that will assume or increase the result in flexion of the hip and result in a more than 90 degrees with that hip flexion, that should be avoided. We can change positioning if there is a need that you have to change the patient's position in bed or turning the patient post-op. That is, I would say, some textbooks will say yes, others would say no. So it's controversial. There is no one clear answer that you can change position because of who would say no because of the risk of the dislocation. Others would say as long as you maintain the abduction, that's fine. So it is controversial in terms of post-op turning in bed. Heels should be off bed because that will prevent the ulceration of the heels. And we have to keep an eye on any signs of hip dislocation. And the two main signs of hip dislocation, and that should be applied also when you have a patient who had fallen or status post fall from bed, especially older adults. You have to assess them before transport. Prior to being transferred back to the bed to make sure they haven't developed a fracture. That same concept should be also applied here post-op, is to assess patients for signs of hip dislocation. And the two cardinal signs of hip dislocation include, how would you know that patient has experienced a hip dislocation or hip fracture, if that's not post-op here. But I'm saying that same concept should be applied to a patient who had status post-fall, right? So that you have to assess the hip for fracture. Same signs, hip fracture or hip dislocation, in this case post-op. What are the two main signs of hip dislocation or hip fracture? You can tell that 99.9%, you can be assured that this is dislocation or hip fracture even prior to being confirmed by an X-ray. The first sign, because when the hip fractures or when the hip is dislocated, then one second. See, how is the head and the neck of femur? When there is a dislocation, which means that the head of the femur is out of the socket, which is out of the stabulum, or in the other scenario, status post-fall patients, hip get fractured, then this one will be shifted up, and the lower extremity will be short. So the affected one will be shorter than the healthy one, and the affected lower extremity the foot will be externally rotated. So external rotation and short affected lower extremity. Two main, I would say, significant, and these are the two hallmark manifestations of fractures, hip fracture and or dislocation post-op. And you can tell that the hip is dislocated or fractured, the hip is fractured once the patient assumes both or one or both manifestations. External rotation, and shortening of the affected leg. So here, this slide also provides the things that a patient should not be doing post-op. Any flexion of the hip more than 9 degrees should be avoided. All of these are recommended and should be taught to the patient even post being discharged. So post discharge from the hospital, going home or nursing home or long term, they also, or assisted living, they should be also taught to make sure that they maintain these tips or guidelines. And the especially with the when they sit on like in a chair or in the shower chair, or they have to use a shower chair in the bathroom, or using the assistive bars, or the putting their shoes on, or the all these are tips to teach the patients post-op to prevent dislocation. Especially with the abduction pillow post-op. So the pillow, we use the pillow between the legs for the first 6 weeks after surgery. So post-op, another or additional like nursing interventions post-op prevent DVT and PE. For example, to make sure patient is receiving the Lovenox or heparin or any type of anticoagulant to prevent the blood clots, especially the hip fractures and post-op, patient will be at risk for for the thromboses. And it's very significant for the DVT to for the post-op for the for especially for this type of surgery, because of the manipulation of the blood vessels that are very close to and next to the affected on the surgical side. It's heavily, there's a lot of blood vessels. There is manipulation of the blood vessels during surgery. It will put the patient at risk to develop the DVT and thromboses. So it is a must that we have to put the patient on blood thinners or anticoagulant therapy post-op. Assessment of neurovascular compromise, which would include the assessment of patient CMS, color, motion, sensation, and peripheral pulses. And we compare the operative leg or the affected leg with the non-affected one.
Can you say that again?
Yeah, we do the neurovascular assessment. You cover that under what is called CMS-PP, which is the color, motion, sensation, and peripheral pulses. So if you perform all the 4 aspects of the acronym, you kind of covered all assessment requirements for the neurovascular compromise. In addition to that, we compare between both affected and the non-affected extremity in terms of the temperature, the perfusion, the if there is any shortening of the leg, if there is any for any signs of dislocation. And then post-op activity. So the post-op activity, the first day post-op, patient will be out of bed with assist of the PT specialist. Physical therapy personnel will be assisting the patient to be out of bed first day post-op. Then out of bed to the bedside chair and stand and pivot. Right after that. Now the weight bearing, now this is the most important piece, which is the how much weight that the patient can put on that joint. The weight bearing status is determined by the orthopedic, given that they have used a cemented versus non-cemented procedure. Cemented, which means that they are going to use the methacrylate, special like cement or chemical. It's like cement that can um, be recommended for certain patients. And the other orthopedic will use non-cemented method. Now, for the cemented method, because of the use of that chemical, then the patient post-op will have either a partial weight bearing or full weight bearing post-op. For the non-cemented, it's always partial weight bearing for a few weeks before they recommend the patient to be using a full weight bearing. So the cemented, either partial or full, but non-cemented is always has to be a partial weight bearing. So this, again, it's the discretion of the orthopedic surgeon to determine partial versus full post-cemented, but non-cemented always has to be a partial weight bearing. And then patients have will be recommend. They will instructed to use assisted devices, a walker or cane or 4-prongs cane, some type of assisted devices for ambulation. This assisted device or ambulatory device will be DC'd when the limp disappears. So when the limping of the joint or the lower extremity will disappear, usually it takes about 4 to 6 weeks to disappear that limping. That's when the assisted device will be discontinued. Now the cemented, there is just one thing about the cement, which is the methacrylate chemical used as a cement for the joint replacement during that surgery. The research has revealed or found that the very small percentage of patients, less than 1% of these cases, they develop a hypotension, hypoxia, and some patients develop what is called cardiac arrest. So due to all of these complications that could result or have resulted from, in these cases scenarios, the hypotension and hypoxia and the cardiac arrest during surgery, due to the use of this specific cement, then I said it's about 0.6 to about 1%, the max. However, that we have to assess the patient post-op for these signs and symptoms, especially with the cardiovascular, like blood pressure, oxygenation, and other cases or patients who had developed fat embolism during the surgery, fat embolism. So this is called bone cement implantation syndrome. Bone cement implantation syndrome, BCIS.
Wait, sorry, what is it?
Bone cement implantation syndrome.
Dr. Miki?
Yes.
And is that for like a specific cement that they use or in general?
No, that's for that chemical. Just I did mention the name of that cement they use.
What's the name? I'm sorry.
Yeah, you don't have, I don't recommend that the name. It's methylcrylate. It's not, it's not something that, I need you to really know the name, but I mentioned the name just for to know it. That's not to, you don't have to recall it. So again, the frequency of using the cement, it's not quite like, frequent. nowadays due to the fact that these results came from research. Detrimental complications due to the use of that cement. Now, the post-op, there is a rehabilitation phase post-total hip replacement. And this slide explains very well, these especially like using the safety bars, the the assistive devices, and in addition to things that assist the patient to execute or do the ADLs, and like the reachers, the wrappers, the dressing stick, and there's a lot of things that they can, that would assist them to maintain a better quality of life, and they can do the ADLs, and they can perform the activities of daily living at a high extent. Now, the total knee replacement, in which that they will replace the three components of the joint, of the knee joint, which is the distal femoral component, the tibial plate, and the patellar button. The dislocation, it's not common status post total knee replacement like in total hip replacement. It's not one of the expected complications like the total knee replacement, total hip replacement. So total knee replacement, the dislocation is not common status post total knee. Pre-op, we will teach the patient about the use of the CPM machine prior to surgery as an expectation to be present and be used after surgery. Because we will put it on, patient will be will be running for sometimes 15 minutes, 20 minutes, 30 minutes, frequent times during the day. So this should be taught before the surgery as part of the teaching about the use of the continuous passive motion machine, the CPM machine. The post-op is very similar to the nursing interventions and care of post total knee hip replacement, except for the CPM machine. Is just, I said that will be used for or post the knee replacement. So the initial setting, so there are specific settings for the CPM, and the setting is usually determined by the physiotherapist. So the PT will determine the setting, and they will sometimes they do initiate this the CPM and program it, and at other times that for example, long-term facilities, nursing homes, they will teach nurses how to set up the CPM, and teach them also how to initiate and how to start the sessions. The initial setting is about 20 to 30 degrees of flexion, because we have the setting includes a few things. The first one is the flexion, how much flexion you want that knee to be flexed, 10, 20, 30 degrees. And gradually, we're going to start with 20 and go to a full extension towards the end of the program, of the full program, rehabilitation program. And then how many cycles per minute? How many flexion cycles per minute? Is it 3, 2, 1 cycles per minute? So these settings you don't have. I mean, I didn't have to dictate specific settings to be known, at least, but that you need to know that these settings, especially the initial setting, that is usually done by the PT, and other times, other long-term by nurses will also learn about these things. So the most important thing about the CPM machine is on the right side of the slide, which is the tips or the best practice for patient safety and quality care when we use the CPM machine. Things to keep in mind and things to be, is recommended, and I mean we recommend, and things also the patient, especially when they are like having dementia or Alzheimer's dementia, and they are going to, have the, the controller close or in reach of patient who is confused, for example, that's going to, change the whole setting and starting to play with the remote control, and that's going to ruin the whole thing. Sometimes results in a knee replace, in a failure of the whole operation has to be redone. So it's something serious to just go through, these best practices, especially with, I always, stress much on this, which is if the patient is confused, place the controls to the machine out of patient's reach. That's very important. When it's not in use, don't ever put it on the floor for many reasons. Risk or fall, or patient may trip, on the, especially not patient, would be patient next, the patient in the other bed probably is going to trip on the machine. So the machine should be placed in a PT room or somewhere it's more safe. The case study, I will go back to the case study after I'm done with the questions. So let's just do fractures, and we'll go back to the case study and the other questions. So fractures. So again, as I said, that the orthopedic content, it will be pretty much included just and integrated in this course, Adult Health 2. So let's go over the most important types of fractures and nursing care of patients post, during and after fracture fixation, and the different types of and modalities, types or modalities of interventions for different types of fractures. First of all, the fractures, there are different classifications for fractures, and we can use the, for example, communicating versus non-communicating fractures. Communicating fractures means there is an open fracture, open like skin and fascia, and part of the bone is protruding out of the skin, and that's when there is a communication between the bone and the environment. That is called communicating fractures. Non-communicating fractures. So, like for example, this one is a non-communicating fracture. This is communicating fracture. That's one of the classifications. And then we have another classification is based on the anatomy of the, like the name of the bone, for example. You can call it also, for example, this is like closed and this is open fracture. There are different classification systems when it comes to classifying the fractures. Spiral fracture versus green stick fracture, for example. The green stick fracture was incomplete fracture. Another classification is called complete or incomplete, stable or unstable. So I'm not going to spend much time on this because it's just the classification. It's about the classification systems. Green stick would be affected by green stick most of the time. Green stick fractures will be affected, like in terms of age growth. Kids always. Children will be, will have like minor fall or a little trauma, even almost like the fall while walking and falling, and results in a green stick fracture, which is incomplete fracture from like minimal trauma. The healing process, so the clinical manifestations and the healing process. So the Before we get to that, I want to highlight something called comminuted fracture. You will see that all the time. Comminuted fracture. Green stick with children, most like affects children. And then the comminuted fracture, that's when the fracture results in a small fragments of bones or bonus fragments. That is called comminuted fracture. Pathologic fracture would be at risk for pathologic fractures.
Older adults?
Older adult with severe osteoporosis, yeah, pathologic fractures. Children who are born with IO, which is in the imperfecta osteogenia. So, which is the or osteogenia imperfecta, which is the congenital disease. You know, children are, the children will be born with that fragile bones, easily fractured. That is also pathologic fractures when it results from that disease, or what is called osteogenia imperfecta. That's the congenital disease. The stress fractures, another stress fractures that will result from like running or jogging, but the pathologic fractures also may result from the long-term use of steroids. So the clinical manifestations, the first sign would be the immediate localized pain. Pain will be localized at the affected site of which is in this case, which would be the fracture site. Localized pain, decreased function of the affected extremity or joint, the fractured one, and then the patient will exhibit the inability to bear weight or to use that part, the fractured part. In addition to guarding from pain, the healing process, that's the pathophysiology. So the healing process, what's important about to know about the healing, the positive factors and the negative factors would promote healing or will delay the healing process of the bone, fractured bone. There is a fractured bone, then there is a positive factors that will enhance, promote the healing, and there is other factors that would, which is negative factors that will delay the bone healing. The positive factors that would promote the healing would include immobilization. You immobilize, because these are now the terms we are going to use frequently today, which is like immobilization, like immobilizing the joint, immobilizing the fractured bone, to make it stationary and to stay in its normal anatomic position and prevent displacement of the fractured bone. That is immobilization. You can use splint, you can use bandage, you can use cast, we can use braces. So there are different modalities to immobilize the fractured bone or joint. So immobilization will be positive. Timely correction of the displacement or the fracture. The faster you correct the fractured bone, that's a positive, that's a timely correction. The more, you can promote the healing process. application of ice because you're going to decrease the or treat the inflammatory response or inflammation. And its associated symptoms like the edema, the swelling, and the pain and increased secretions. The negative factors would be if there is osteoporosis. I mean, like patient is diagnosed with osteoporosis, advanced age. The healing process with older adults will take way longer than the patients in a younger age. If the patient is immunocompromised, if the patient is receiving a steroid therapy, malnutrition, because to promote healing, we always say, we have to add like calcium and vitamin D supplement to promote the healing. So the malnutrition is a negative factor.
What did you say before steroid therapy? I know you said old age, malnutrition.
Immunocompromised.
Okay, thank you.
Yeah. So now the reduction in orthopedic as a term now, this is one of the most important concepts and modalities in orthopedic management or management of fractured bones called reduction. Reducing the bone here, reduction here in orthopedic means realigning both ends of the fractured bone together in a normal, or to go back to its normal anatomic position. The fractured bone usually is displaced. Both fractured ends that are not aligned to each other. To align both ends of the fractured bone, then that is called to align them to maintain the normal anatomic position. That's called reduction. To do that, because otherwise, if you allow for for displaced bone, fractured bone to heal, that will result in a deformity of the bone, and most of the time that's result in a shortening of the affected extremity, especially when it's long bone, right? So now we have something called closed reduction versus open reduction. So the closed reduction, which is the non-surgical, it's non-invasive procedure, and can be done by aligning the joint manually, and that's usually done under the X-ray, continuous X-ray, like CDH, for example, congenital dislocated hip in children. Congenital dislocated hip, sometimes it's done, depends on the severity of the CDH. It's done sometimes via closed reduction under the X-ray, and then after that they will apply the hip spica from the waist down to the knee or above, slightly above the knee. Children with CDH will, they treat the severe cases more than just subluxation. The incomplete dislocation of the hip in, like for example, in the children or neonates or children, that is called subluxation. That's incomplete dislocation. With severe dislocated hip with fibroses and probably at older, like an old age, maybe like 6 or 7 or 10 or 11, then they have to do the surgery. It has to be done via open reduction. They have to do a surgical incision and then fix the the fibrosis, and they will fix the head of femur and push the head of femur into the acetabulum, and then they apply the hip spica or the cast. So that's called open reduction. So open reduction, it's the invasive procedure to fix the fractured bone or dislocated hip, for example. Closed reduction is just the manual manipulation of the fractured bone that can be fixed and placed, and then right after reduction, to maintain the anatomy of the fixed position, you have to apply some type of immobilization. Traction also is another way of doing reduction. To reduce the bone, sometimes you cannot do it manually, or even it's not recommended to do it surgically. So what we do is that we apply something called some modality called traction. We do apply weight and ropes, and like a rope that's going to be attached to the patient's extremity, and then weight is hanging or attached to the rope. So that weight is going to pull against counter traction against the patient's weight. And there is some calculations and mathematics, and math that goes into the, and equations and physics goes into the traction when it comes to how much weight to apply to be effective to pull the fractured, for example, lower extremity and do the skin or skeletal traction. So skin or skeletal traction can be done for the upper or lower extremities fractures and to reduce the bone. In other words, to realign or to resume a normal anatomy with the, the previous or the normal anatomic position of the fractured lower or upper extremity. And then, so reduction is to fix the fractured bone, make it, to reach or resume the normal anatomy. And then after that, we have to apply some type of immobilization. Otherwise, without immobilizing the bone, the fixed fractured bone, then you cannot guarantee that that bone, the fractured bone, is going to go back to its displaced form again. So to maintain it within the normal anatomy and the normal anatomic position after being reduced, we have to apply some type of immobilization, cast, raise, splint, bandage. So it depends on the fracture, the type of fracture, we will apply immobilization. So the immobilization would be next. Skin versus skeletal traction. I'll explain the difference between skin and skeletal traction. The skin traction usually used for skin for short-term treatments. For longer periods, we will apply the skeletal traction. Now, the purpose of the immobilization is to prevent further injury, to promote the healing and circulation, and to correct deformity. And there are different types of immobilization. As I said, cast, splint, brace, traction, external fixation, cast like this. And there is something called cast syndrome, especially will result when there is a pressure on the patient's abdomen. An example of that would be the double hip spica. And this is the type of cast that will be applied for the children who are underwent the CDH, surgical fixation of the congenital dislocated hip or hip dislocation. So they will apply hip spica for these children, and they will have it for a few weeks, if not months. So cast syndrome is one of the complications expected. We have to assess for that. The patient generally complains of abdominal pain, pressure, nausea, vomiting, and treatment would include, as the slide says here, to include would include the NG tube decompression with NG tube and suction, attaching the NG tube to a low suction. Cast either to be removed or like replaced, or sometimes we can do a split so we can relieve the pressure, because that obviously is resulted from the pressure on the abdomen. That's called cast syndrome.
Dr. Mickey?
Yes.
Why did they leave like a hole in the umbilicus area when they do the cast? I see that several of them have like a hole in the abdomen area.
For assessment. So that's to prevent the cast syndrome. That's That's to relieve the pressure from the abdomen. That's the window to relieve the pressure from the abdomen. And if they develop the cast syndrome, then we will create a further, like on the top of that hole, we will create another like slit to relieve the pressure from the abdomen. That's in scenarios patients develop cast syndrome. So I'm going to read off. I'm not going to read off, the slide, but these are the most important tips, things that can be done or should not be done or avoided during and post cast application. And it's very important that we digest, these steps and know them, because we can prevent a lot of complications. And the most important complication post cast application is the pressure from when the cast is dry out, then it's just cannot be, has to be removed if it's too tight, especially the lower or upper extremity, which means that that extreme pressure or high pressure on the extremity result in a cut of blood supply, and that should be removed, or we can sometimes either remove it or replace it, or do some type of what is called window or slit, or we have to relieve the pressure to prevent the cut of blood supply to the lower or upper extremity, and we can prevent what is called the compartment syndrome. And the resultant, I would say, detrimental complication from the compartment syndrome is a complete cut blood supply for a long period of time, not being identified or noticed or assessed and noticed by especially the nurses. That would result in necrosis and eventually, and I would say, unfortunately, that we have to amputate the limb. So amputation could be the one of the complications, or treatment, or in this case would be treatment. The last resort to be done is to amputate, because there is a necrosis and that tissue should be removed. So the removal of the tissue is called amputation, and in this case it's a limb, upper or lower extremity. So the compartment syndrome is one of the important post-op things to remember, and that nurses need to do the assessment frequently, like at least like every 30 minutes, 45, 1 hour post-op, to maintain, make sure that there is a continuous perfusion to the lower or upper extremity. So things, the immobilization, we have external versus internal immobilization. The external ones, which is, I have few pictures explain the external immobilization. It's still invasive procedure, both invasive procedure. But the external, external type, you will be able to see and manipulate and manage the fixation. We are not allowed to change, modify, adjust, or do any type of adjustments to the external fixators, or even this patient should not be using the fixators to change position, or to should not be used for changing their position, or during the ambulation to lift the limb or something like that. So that's something should be avoided, because that will result in increased to the displacement and to the failure of this device. The internal fixation is the invasive, also it's invasive procedure, but you'll be, once it's the skin is closed and sutured, then you won't be able to see that device. It's like pins and plates, for example, pin and plate, or plate and pins and screws that will be implanted, and that will to fix the fracture, and you won't be able to see that of the skin, or externally nothing is going to be shown except for that sutures or staples. The like this one still is external fixator, an external fixator, that's an X-ray. An example of the internal fixation and the common surgery is called ORIF, open reduction internal fixation. So opening the skin, fascia, muscle, fix the fractured bone or hip fracture here, and then you apply, let's see, osteomole or pins and plate, screws, and that is called open reduction internal fixation, because you have to open and then fix the fractured anatomy. I mean, the anatomy of the fractured joint or bone. That's called reduction, and then internal fixation. So open reduction internal fixation, ORIF. That's why you frequently will see this open reduction internal fixation abbreviation in patients' charts. Now, skin traction, it's either skeletal versus skin traction. We said that skin traction is usually used both for reducing the bone and for reduction. And the skin traction is for short-term periods, and then the long-term periods we use skeletal traction. Skeletal traction is invasive procedure. Skin traction is it's not invasive, non-invasive procedure. So this one is the skin traction. Then we apply adhesive tape goes around the skin, and then there is a rope, poly, and then a weight hanging. So that's skin traction. The skeletal traction, there is a rod that is going to penetrate the bone, and then rope and poly and weight to pull the fractured bone. So to realign it, which means to reduce it, that's for reduction. That's called also a skeletal traction. So skin versus skeletal traction. Skin traction, Ryan's traction is one type of skin traction in patients and children with sorry. Let's go back. Yeah, Brian's traction, which is like this kid with this type fraction, it's called Brian's traction. This is a skin traction. Another skin traction, Brian's traction. That's the name of the traction, Brian's traction. And that's to correct the congenital dislocated hip. Congenital dislocated hip is at early phases of the disease process, or not severe scenarios. It can be done by a skin traction. The skeletal traction, again, it's an invasive and requires that rod to be metal, piece that goes, penetrate the bone, and then there are 2 insertion sites. So you have to maintain the insertion sites clean every day to do the surgical, like a wound care for both ends, for both like insertion sites, given that it's an invasive procedure, and that to prevent the osteomyelitis. So the nursing management includes the prevention of infections post fractures. So the osteomyelitis, we said that osteomyelitis is one of the expected complications, acute, and then what may become also chronic. And we covered that at the outset of the lecture last time. The open fractures require aggressive surgical debridement. Post-op IV also will be intravenous antibiotics will be used for about 3 to 7 days post-op to fix the fracture. 3 to 7 days of using the antibiotic use intravenous. That is recommended to prevent osteomyelitis. This is about the compartment syndrome and how to assess for the compartment syndrome, the 6 Ps. Post-op, sometimes if the patient develop an infection, and you can tell from the oozing or from the, it will come through from the infected wound, the secretions or discoloration or spots of a blood or sanguinous or pussy, but you can tell, from the from these signs that there is an infection. So they will open a window, and that's which is called the bivalve. So the bivalving the cast, which means opening like small window, to first to inspect and make sure that that first of all that this to inspect the wound and make sure it's infected or not, and if there's an infection, we will treat it with wound dressing and treatment daily, and once it's healed, then you can cover it. But that's and we cannot ignore the infection because it has to be treated. Otherwise, the infection of the site itself can result and lead to and progress to osteomyelitis. So that's what's called the cast wedge, or what's called the bivalving. So this is the opening the window in case the patient develop an infection of the fractured of the site, like the wound post-op.
Dr. Mickey?
Yes.
But how would they know like where is the infection at, or is
No, I
it
said through. Yeah, I mentioned that you will notice that there is some type of like drainage coming out, see through the cast, because the cast is a fiberglass or POP, plaster of Paris. So it will leak through until you see like spotted areas, and you can tell that that will be you can keep like opening windows until you find but you can tell from the dry secretions or dry leakage of secretions that coming through to be spotted on the cast, and you can tell that there is, because that will be one of the signs. Also, pain is another sign. If the patient has experiences any like severe pain at the site, continue to be like severe at the surgical site, that's another indication that we have to open a window and investigate. Then other complications or expected complications post-op: fractured bone, that will be like VTE, which is thromboembolism, the fat embolism. And the patients with fat embolism, they will experience pretty much symptoms very similar to a patient with ARDS, acute respiratory distress syndrome, like chest pain, tachypnea, cyanosis, decreased PaO2. The 3 hallmark manifestations of the fat embolism is dyspnea, tachycardia, and patients become apprehensive. These are 3 like main things that could at least alert and warn nurses to assess for the signs and symptoms of fat embolism. We covered this in pathophysiology. We said that the fat embolism is one of the conditions that difficult. There is no clear scientific explanation why patients would develop the fat embolism post-fracture, but first of all, it affects the fracture of long bones, and it's believed scientifically that the protein molecule will enter the bloodstream status post the fracture of long bones, and that fat embolism results from the protein invasion or traveling into the bloodstream, and then that will result in the embolism. Amputation, the amputation would result due to or secondary to a trauma, like motor vehicle collision, other type of injuries, compartment syndrome. Late stage of compartment syndrome could result in a, we have to do the amputation. So the clinical manifestations, the circulatory impairment results from the decreased perfusion, basically, like the peripheral vascular disease, traumatic, and thermal injuries. These conditions may manifest as loss of sensation, inadequate circulation, and manifestations of like sepsis or septicemia. So patients will undergo this type of surgery, the amputation, because of the effect of, for example, PVD, atherosclerosis, vascular changes, for example, related to, for example, the diabetes mellitus. So some of the complications from diabetes is that patient would develop the cellulitis, and then necrosis, and then gangrene, and then gangrenous tissue, and then the amputation should be the last resort or last modality to be used for that patient for the necrosis. So the most important post-op or post-amputation nursing care is to prevent complication. I mean, the most important aspect of the nursing interventions post-amputation is to prevent complications. And the first important one is the flexion contractures. Flexion contractures, and there are specific like guidelines how to prevent the flexion contractures. So the fracture is right here. This is a displaced fracture of the distal radius. And there is also a dislocation of the distal ulna. But this is very prominent, very obvious here, that say that this is a displacement fracture of the distal radius. In addition to, there is a dorsal dislocation of the distal ulna. That's very minimal, but this is very obvious. Now, the treatment for this fracture would be open reduction. They have to open, like skin, fascia, muscle, and then to get to the bone and to do the internal fixation. So they will do the open reduction internal fixation, ORIF procedure. Sorry. If that's child, that's the adult. That in adults, we will do the open reduction internal fixation. In children, usually they do the closed reduction, and they do apply the cast after that. Closed reduction, like they try to manipulate the fracture, because most likely it's going to be like green stick fractures, and they will manipulate the fracture under this X-ray continuous X-ray, and once it's in, maintained in the normal anatomical position, then they will apply the cast, and that will be the treatment for, if that's a child. And the adult, that's different. That has to be the open reduction internal fixation procedure. So I think, yeah, we have to stop. I know there's a lot of information here. And I can, next time, we can go over the questions and answer the previous, the ones from the previous slides, as well as the upcoming questions.